All right, so my second one, this is, I think he's 23, bicyclist, hit by a car, is a super active cyclist kind of kid that's like, I don't want to own a car, so I ride my bike everywhere, and he, rolls up one side of his jeans because he's all into the cycling thing. So it kind of feels like round two, the same thing for my cases. Otherwise, he's got banged up a little bit, but he's cleared for surgery. And so kind of standard here, he's got an AP pelvis. We see that varus displacement on the lateral. We see some anterior angulator or, retroversion, gapping anteriorly on the CT scan, looking at the patient's left side. Even more so than the last one that I showed, more tension failure anteriorly, more retroversion. And then what made this one a little more challenging, he's got a little more comminution, which doesn't show super clearly here, but you sort of see some of the comminution through the center of the neck there. So without sounding like a broken record, we did a little bit of an open reduction, and I had cannulated screws planned for this. And my problem with that was, of course, knowing there was going to be collapse because of this, the comminuted pattern. So on the right was sort of my first try, and it just didn't look right to me. I had some, this inferior neck piece, just didn't have anything holding it together. And, the periosteum and the hip capsule is a little bit different. So I kept working and I kept working, and I put my little tensioning clamp out in the front and put a few more guide wires and different trajectories, and just couldn't make it work to the point that I felt comfortable. And this is all with a small amount of femoral traction, but enough that it does offload some of the muscular pull, but I knew that was going to have to come off at some point. So I then decided, okay, well, I like where my reduction is at this point. I've now got a clamp really getting that inferior neck calcar piece, and then clamping that towards the greater trochanter. And I started to like my reduction. And now I go to my old faithful implant. So I've got my sliding hip screw foot plate here and my 135 guide wire coming in low and going center. And then on the lateral view, making sure I have that foot plate, that's my wire guide, really lined up on the shaft well, because where I put that now is where my plate goes later. So making sure I had that lined up, get my wire up there, buried right into the subchondral bone. And then this is a young person. So number one, I don't want to just put my screw up there because it's a non-self-tapping screw. And number two, I just put a screw in order to compress and sort of get whatever valgus I could get out of this pattern. So I've got a partially threaded screw with a washer trying to really pull the head up into as much valgus as is anatomic. And then that on the right side, there's the old school. It's a tap so that I could carve a pathway for this screw and not just ask the threads to twist it off. Because my fixation here is now, a 2.8 millimeter guide wire and a single small Weber clamp. So I really don't have a lot of stability at this fracture site. So I'm tapping, and then I put in my sliding hip screw. And this is all still with the skeletal traction on. It's 5 pounds, but the guy's anesthetized. And so that's where I am when I say, okay, we're good. Final images, AP lateral. I'm super happy, stoked, high fives all around. Everyone's happy. And then on the left-hand side here, this is his PACU image. This is 10 minutes later, or 30, resonant closure, but 30 minutes later, and he's already shortening. And then on the central image there, that's at his 3-month follow-up. And so you've got a nice little gauge at exactly how much he's shortened, because I can measure the distance from the base of the threads to the end of the collar, or I can measure from the head of the lag screw to the washer. Either way, it's very clearly shortened. However, he has not gone into retroversion, and that's where I think the power of the sliding hip screw with those 2 cortical screws preventing any rotation. So if you look at the lateral, the head's still lined up on the neck. So I was not thrilled, but I was also not feeling like the cat was out of the bag. And I think we still have options because it's still alive. I guess this would be the time when I ask people, what would you do now?
How old is he again?
He's like 23.
Is the derotational screw, is that symptomatic for him when he's bicycling or doing whatever he's doing?
Well, he's not quite back to cycling. This is when I said, okay, you can start to walk. And he came in, he's like, yeah, I'm kind of sore. The lateral side's a little sore. I don't have any point tenderness, but it's not my favorite thing. But I've been off it for 3 months, so I don't know if it's sore or not.
I might want to get a CT scan at this point to see if there's any evidence of bridging or any bone growing across any aspect of that.
I don't think I have it, although I did get it.
Okay.
And it shows that it's kind of compressed together. I think there's a lot of metal artifact on the CT. So I think you can make an argument. There's a little bit of spot welding here and there. It's not necessarily done healing, but at 3 months with that much collapse, it kind of looks like it's trying, like it might heal if we give it time.
Might template out an osteotomy and kick it up and see if how much offset that buys me, and see if that's an option.
So you're thinking of valgus intertrochanteric osteotomy, pull the implants out, blade plate.
Mm-hmm.
Yeah.
And see like, playing with osteotomy options to see if I can do something that'll give me a little bit of length and offset.
Yeah. Well, and that's where the real planning comes in with a case like this, because you can, there's things like bone setter that are free and easy, and you can sort of cut and move things around pretty simply and get an idea of what it's going to look like. And I think it's faster than drawing, although I've got my templates out here because I still do it, but it's really helpful to just get an idea of what things are going to look like. And it's, you can cut and paste and copy and sort of duplicate things a little faster. But in the interest of time, I'm gonna cut forward. So here he is with his implants out. And what I notice here is that he's got this coxa breva, right? He's got a shortened femoral neck. So we've lost length and offset. So it's, we've lost it along the axis of the DHS. So what I actually elected to do here was, because he's so short, I thought I was going to lose, he's going to turn into a very vertical femoral neck if I did a typical intertroch osteotomy. So what I did is I did a extended retinacular flap with a trochanteric osteotomy. And instead of a valgus producing osteotomy, what I did is I took off his greater trochanter and I debrided the residual neck sort of in this region, so that you can see I've got more of a recess. And then this is an allograft femoral head spacer to move his trochanter back out lateral and to distalize it. So if you kind of compare where the trochanter is compared to the center of the femoral head on this image versus where I've got it on this image, you can see it's been distalized pretty significantly. And so by debriding the neck here after carefully doing a retinacular elevation, this is a relative neck lengthening. So there's no change to the actual neck length here down low, but by positioning the trochanter further lateral and further inferior, what we've been able to do is to move his abductor moment more lateral and more distal to reestablish the pull since the neck is shortened. And that was in May, and he just came actually this past week back, and here he is. And obviously it's not a normal hip right now, but his neck has definitely gone on to heal. Although it's not a perfectly round head, I can't say I see any real sclerosis or even FECOT1 like collapse or anything that makes me think he's going on to AVN. And I'm stoked with his troch position. I think there's some things I can do to make it better, but overall he's just started to increase his exercise now. He's feeling stronger. He's getting back on the bike, and I'm thrilled with this outcome.
Yeah, it's a nice looking X-ray, to be honest.
James, I got a question for you on that one. And honestly, that salvage is a really cool case. I mean, that is not a PGY2 case. But my question for you is, and I noticed this on your fluoro films, there's a bunch of ligament clips that you see there. And that's one of the things that one of the guys that I trained with would argue about, if you can get it pretty close, he preferred to not do open because when you do that big anterior approach, you invariably are going to take a little bit more blood supply. And just my only question is, what did you have to clip off there? Because do you think that may have affected the ability for this thing to heal with the first one? Because that reduction on the initial film looks spectacular.
Yeah, it's kind of as you're moving and it's clearing off the capsule to make a T capsulotomy. Instead of using a bunch of bovie where I might get stuff other than what I'm looking at, I use the clips, but I totally agree. I always feel like it's like you're starting a fire to clear for a forest fire. Like am I making things worse to make them better?
Right.
And in this one, I think the fact that it was so comminuted, I just didn't have a way that I could line it up to the point that I was comfortable putting screws across it, because I felt like I was just going to get everything to shorten. But I struggle with that's exactly the reason that I think, okay, if we can get it closed, let's just get it closed. But for this one, I didn't feel comfortable moving in that direction. So, and full disclosure that I did a 9 months in hip preservation surgery. So doing trochanteric osteotomies and extended retinacular flaps, that's my jam. I don't expect a general orthopedic surgeon who's taking trauma call to be doing this in their follow-up, but you can always send them to me.
I will.
Yeah, those the crossing vessels. The thing is, they kind of run along your operative field there. So even if you get them once and ligate them, you can kind of repeatedly run into them, and so that's why you end up sort of doing it again and again and again.